So, talking about the pathomechanics of the joints. Pathomechanics means the mechanism or the mechanics means movement of the joints is pathological, means that is impaired. There are some biomechanical concepts that needs to be taken into consideration. First and foremost term which I'll be using is movement. It's not movement, just to clear for BPT first and second year students. It's movement, M-O-M-E-N-T. Different from movement in the context that movement is the force that is causing some change in the alignment of the bone in some certain direction, or that has the strength to generate that movement. So that is movement. Now, on the aspect of biomechanics and pathomechanics, first and foremost thing is we can talk about a certain particular joint, like let's say knee osteoarthritis. So what happens is there are certain areas of the joint cartilage that are more involved in weight bearing. So when you are walking, some areas are more involved, some cartilage areas are more stressed than others, and some areas not stressed at all. So that way what happens is the areas, the cartilage structures, the cartilage surface, certain parts that are being stressed more gets accustomed to that extra stress and they are easily adapted. But at the same time, there are certain areas that are not well suited to that stress. So ultimately, they are not accustomed to, they don't get any stress, so they are lying easy, they are, residing in the joint, they don't do anything, they are living happily. But what happens in case of pathomechanics, those areas which were not accustomed to taking that extra stress, now they are getting that extra stress in terms of walking, and that is because of your faulty posture, your footwear, your other component, your training style, training habits, the surface you are walking upon, and muscle weakness, altered joint angles, extra rotation, altered movement arms. So these things will ultimately lead to changes in force distribution around the cartilage surface with extra force on the areas that are not well suited to take the extra stress. So ultimately that leads to increase in the degeneration. Along with that, as I discussed with you, in primary osteoarthritis, aging leads to degeneration in the areas that are less adapted. Or the other way around, I can correlate it with the thing you learned earlier, that the synovial fluid nourishes the articular cartilage. But what happens is, in the proper routine of nourishment, when there is weight bearing, the nourishment is more because the fluid goes out and then comes in. So it's sweeping out and in of fluid. But if a person is immobilized or he's not moving, so what happens is there is more degeneration. So the area with lesser stress gets more degeneration in the initial being when you have no symptoms at all. And afterwards, the areas which have been degenerated will degenerate more with extra stress. So initially the areas which are not getting any stress will be stressed more. Afterwards the same areas will be stressed with more weight bearing or activity. Now as we discussed, the joint angles play a big role in this thing. So let's say if someone has flat feet, the foot goes into eversion, the tibia rotates internally, there is more of valgus at the knee, and that leads to lateral compartmental compression and knee osteoarthritis. On the other hand, there are some people which is more predominant. Some of them have external, that is varus component at the knee because of increasing valgus movement or the adduction movement at the knee. So that increases the adduction movement, and ultimately along with that there is increased tibiofemoral rotation. So all these components, these pathomechanics lead to increase in the prevalence of osteoarthritis and the changes you see with osteoarthritis. Now if we correlate what all issues patients do have and why they happen. So the first and foremost issue, you see a patient with osteoarthritis and they'll be walking very slow. And the reason behind that is, whenever they walk, there is, because of they might be having extra obese build along with weak musculature, or even if it is not there, they get extra stress. So when they are walking, they are placing their foot on the floor, there is more of a adduction movement, the ground reaction force is more, and the net force on the joint increases, leading to more compression and more pain. So the faster you move, the more the ground reaction force and more the joint compression force. So that is why they move slow in order to compensate for the extra ground reaction force that is coming. So the slower you move, the lesser ground reaction force, so the lesser the pain. Second thing, you see them walking something like this and this, swaying side to side. This is because of weakness in the hip abductor musculature. So what happens is, normally in a healthy individual, when you are on, like in the gait cycle, when you are walking, when you place one foot on the floor, the other foot will be in air. So when the other foot is in the air, so the pelvis on the opposite side, let's say if the right foot is on the floor and the left foot is in the air, so the left pelvis is unsupported. Okay, because when you are bearing weight on both the feet, both pelvis are supported. But when you are bearing weight on the right leg only, the right pelvis is supported, but the left pelvis is lying in the air. So who's supporting that? It's the hip abductor muscles of the right side that support the pelvis up. So that abducts the right side of the body, the right leg, and at the same time the left pelvis will be stabilized. But what happens in patients with knee osteoarthritis or hip osteoarthritis, that the hip abductor muscles get weakened up. So as they get weakened, the strength decreases. They are not able to hold the weight of the pelvis that is and the leg that is lying in the air. So as they are not able to hold it, the leg tends to fall down. So to compensate, because the leg is falling down, what the person does, as the left leg goes up, to compensate for the drop of pelvis, they lean towards the right. And as they place the left feet forward, now the right feet is in the air. So now the right foot will go down, the right pelvis can go down now. So to compensate for that thing, they lean to the left. Likewise, they keep on shifting and swaying their trunk to the left and right and bending to the left and right to compensate for the weak abductor muscles of the lower limb. That ultimately leads to the waddling gait in these patients. Alongside, you see a classical thing, that is, they have a widened base of support at the stance. So they place their feet wide because there is balance impairment in osteoarthritis. Because you must be well aware of the fact that our joints have got proprioceptors, our joints have got kinesthesia receptors. So what all these structures do, they give sense of movement, change of direction, the force produced on these structures. So because of muscle weakness, the muscle spindle is not acting properly, and at the same time the proprioceptors, kinesthesia receptors and all are not giving proper stimulus to the brain that which position you are in. So that ultimately leads to decrease in balance, and so the patient compensates the decrease in balance with a widened base of support. So there is a widening of the base of support to compensate for the decrease in balance. Then there is an outward pointing of the feet. Why is that so? See, why I'm telling you everything so detailed, because I don't want you people to just learn that okay, there is a wider base of support, there is a outward toeing, then you have pelvis shifting side to side. You should be knowing why that happens, the idea behind that thing. So talking about outward toeing, so what happens is there is increase in the internal rotation at the femur in case of knee osteoarthritis because of the increased movement, and that leads to increased moment of adduction movement increases, so that leads to increased internal rotation at the knee. To compensate for that thing, the tibia rotates externally because the femur is going internally, and we need to, if we don't turn the tibia outwards, it will go with the femur internally, both the feet will be like this, in toeing. To compensate for that thing, the tibia rotates externally and it compensates the overall lower limb mechanics. So that is why these people have a out toeing while walking. And at the same time, you have medializing of the knee, because as I told you, there is more of adduction movement at the knee that leads to increase in. So this is the femur, this is tibia, this is the knee joint. There is more of adduction movement, means it's going like this. So varus at the knee, right? Now to compensate this varus, they should do something that can take this back, so making the knee straight. So that knee straightening is called medializing of the knee. So that is what they incorporate into their walking, and that is a peculiar pattern you need to look while assessing a patient with knee osteoarthritis. See, being a movement scientist, you need not to go with the idea that okay, I need to prove it osteoarthritis. You should be the one who should be having at least 10 diagnoses for a joint, for a condition, and out of those conditions you should come out with the idea that it is not this, this, this. Excluding 9 things, you come to the last thing that it is this thing. Okay, so likewise for this thing as well, you'll be assessing each and every part of the body. You can't stop at one particular point that okay, I got this, oh, we have knee pain, we have synovitis, and Nitin sir told us that this we can see in osteoarthritis, or this is OA. No, this is not OA. You have many other things. When diagnosing knee osteoarthritis, you should get an X-ray done. That will show you the osteophyte formation. That will show you what I told you about the cyst, radiolucent cyst below the joint margins. That will show you the bony remodeling that has happened because of the overstress. That will show you the sclerosis at the bone ends. That will show you the musculature. Okay, now you'll be thinking, I'm saying musculature in an X-ray, right? Normally you see just the joint in an X-ray, just the bone in an X-ray, because bone is radiolucent and muscles doesn't have any that much calcium content that you can see it directly through the X-ray thing. But no, when you take a knee X-ray, when you take a hip X-ray, you look it properly and you will make out their margins. They are proper muscle markings you can make out, and it will give you a fair idea what sort of muscles are there in the that particular patient's limbs, how it's supporting. Not fully, but yes, at least you can get some idea with the thickness of the muscle. So yes, you can see muscles as well. That's something different from the text, and you should try it out yourself as well. You will see muscles in an X-ray. Okay. Alongside, you can go for MRI, you can go for CT scan, though not normally done in case of a osteoarthritis, because it's not that much needed actually. But yes, it can give you a beautiful clear-cut image of what osteophytes are. You just see an image, MRI film of shoulder osteoarthritis or knee osteoarthritis. You'll find out the osteophytes coming, the 3D scan, 3D CT scans you can see. So that will show you the actuality what's happening inside the joint, because that you don't normally see without opening up the joint. So that is what you can get in a 3D CT scan. Likewise, you have certain special tests as well for the knee joint that help you to diagnose the condition. But because of time constraints, we will be discussing the special test in a separate series. So that will be exclusively for special tests for all the joints. So in this series, so this was all about diagnosing the condition. So these things you need to mark out in the X-ray. Along with that, the major symptom you can see in a patient with osteoarthritis is, stiffness. They get stiffness, that is, the muscles and the capsule is getting stiff. So you'll get a classical complaint. I'm sitting for let's say 20-30 minutes or 1 hour, and then I'm trying to get up, I'm not able to move my joints. They are so stiff. I'm sitting on the chair, I'm trying to get up, I'm having pain in my knee or in other structures. Why? Because stiffness is there. And what happens is, to compensate for this thing, they use compensatory patterns, ultimately leads to decrease in postural adaptability and the muscles gets further damaged and further weakened. So that is what we don't want to happen in our patients. So coming to the best part of this series, that is the treatment aspect of these patients, and that is not simple treatment you do, let's say isometrics. Every patient who comes to you, okay, knee OA, give him isometrics. 10 patients come, show them isometrics. No. It is exclusively based on the pathomechanics that you decide what all you need to do for that patient. Even if it is a knee osteoarthritis, you need to be very much cautious that every patient is different. Every individual is different. You need to treat them the way they have the issues, the pathological conditions they have, because they would be coming to you at the age of, let's say, 40, 50, 60. In the last 40, 50, 60 years of their life, they must have endured many things. Their joints have got many injuries, or if not, they would have got some postural issues or something that has led to that problem. So you need to be very cautious in determining all those pathomechanics of the joints, the joint angles, the way the joint moves, and that is a separate unit. We'll be discussing that and how to assess a patient, assessing the patient on the basis of all the techniques you have. So on that basis you will decide. Okay, so now coming to the most interesting part of this series on osteoarthritis, we have the thing that I promised you in the very beginning. That is the component that either you are a neurophysical therapist, an orthophysical therapist, sports or cardiophysical therapist. All of you are gonna get benefited from this series, because I'll be discussing the specific areas you are dealing with. So starting with a person who's dealing with spinal cord injury, that is neurophysical therapist. Many a times you see a patient with spinal cord injury in which the key muscles below, the arms are spared, the trunk is spared, but the legs are not working. So in that case, what we prescribe is, okay, we give him a wheelchair or crutches. So being in the wheelchair, and when the patient is propelling the wheelchair, it has been seen that even in the very first year, 1 year after the spinal cord injury, after that trauma and everything, there is more than 8% of degeneration in the articular cartilage. The articular cartilage gets thin by 8% of its actual width. So that leads to increase in shoulder osteoarthritis. So that was all about neuro aspect, that even a patient with spinal cord injury can get an osteoarthritis, and that is we don't take care of that thing. We are always focused about, okay, we need to take care of the legs, we need to take care of this thing, pressure sores, this and that, but he is complaining with, okay, I'm coming with pain in the shoulder. We'll say, okay, it might be something, we are concerned about your legs. So it's not so. You should be multifaceted, you should be multitasking, you should approach the patient in every possible way, because he is your patient, he or she must be kept in utmost care and should be dealt with utmost care. Talking about ortho and sports people, we have elbow osteoarthritis, specifically in manual laborers, athletes, javelin throwers, and weightlifters. You have elbow osteoarthritis because of the excessive pressure and stress that's being put on the structures of the elbow, and that leads to elbow osteoarthritis. Coming to dancers, we have specifically ankle and foot osteoarthritis, specifically the metatarsophlangeal joint, that is the first metatarsophlangeal joint, gets readily involved in patients, in individuals who are specifically dancers, because in ballet dancers what happens is they are putting stress on their front ray and the front phalanges. So the metatarsophalangeal joints get extended. So what happens is with that they put excessive stress on that area, and that goes into degeneration. And it has been seen that the stress have been 20 kilogram on 1 centimeter surface area. So that's a big deal. 20 kg force on such a small area, just 1 centimeter area, will lead to osteoarthritis because it's more of a wear and tear again and again, and they are practicing like anything. Coming to the other patients, you can have in sports, you can have hip osteoarthritis. And in hip osteoarthritis, believe me, that is something you have in patients who have more of a rotatory movement, like in soccer, football. You have baseball pitching. You have other cases in which there is more of rotation component involved, and it puts excessive stress along with strain and rotatory component. So that leads to more degeneration in the articular cartilage and more deformation of the joint structures. Last but not the least, it is something related to physical medicine and rehabilitation. You see a amputee, a patient who got his transtibial amputation, and after getting the transtibial amputation, he is complaining of pain in the knee. It is not always that it is due to the amputation thing that the nerve stump or something is giving him pain. It might be knee osteoarthritis. I'm telling you, mark my words, it might be knee osteoarthritis, owing to the fact that whenever they are walking, they have a prosthetic feet. The feet is not enduring the normal ankle toe movements that we have. Normally we start with heel strike, then flat feet, mid stance, and then heel off, then toe off. They are not walking like that. They are putting their heel, then complete feet. So the normal mechanics is disturbed. So that way what happens is the force that's going from the ground directly goes to the knee, and with every step they are putting on the floor, they are giving extra stress to their knees. So that leads to extra wear and tear in transtibial amputation patients, leading to more cases of osteoarthritis in this population. Okay, so this was all about osteoarthritis. Now we'll be dealing with, and I'll be making one more video on the treatment and rehabilitation of these patients, and that will be exclusively based on the pathomechanics of this thing and the issues the patient has got. It will not be something that we need to have rote learning. We should be having concept and ideas. Then you can frame treatment for any of your patient. So with that in mind, we'll be discussing as we discuss the pathomechanics, we'll be engaging all these ideas into the treatment, ultimately leading to a patient who's maximally benefited from our treatment. So I want to share my views and ideas with all of you so that the physiotherapy profession can grow and we can take it to the next level. So with that thing, I bid you a goodbye, but to meet you again. See you, take care.